Thank you very much, Fiona. Good afternoon. I would like to thank the BMJ Group and the Evidence Center for inviting me to this very informative meeting, and also would like to congratulate Fiona and Carl for putting it together. So my remit is to speak to you on strengthening evidence for rational investment for addressing NCDs, particularly in low and middle income countries. That would be my focus. But please feel free to interrupt me if you have any questions. I'll be quite happy to respond in the middle at any time. So last month, as Fiona mentioned, there was this landmark event, the New York United Nations General Assembly session, a high-level meeting on NCDs, which brought together heads of states and also about 120 ministries of health, ministries of finance, etc. And what I would like to do is speak a little bit about this landmark event, but also the global and national response over the last 13 years in addressing NCDs, the kinds of evidence that fed the process, and how evidence has been used to rationalize investment and priority setting, and also the very difficult task of translating evidence into policy, particularly in low resource settings, and how we have used, and different groups have used, levers and also various ways in overcoming barriers to translate the already existing evidence into policy, and also key milestones during these 13 years. So the UN high-level meeting was only the second time in the history that a health issue had been addressed by the UN. And one good outcome was that it firmly positioned the NCDs as a development issue and not only as a health issue. And of course, this is very important in reframing the discussions, particularly at the global and also at the national level, in the post-millennium development goal era, which will begin in 2015. And the process that led to the political declaration, which was the document that was adopted by the UN General Assembly, the process was as important as the document itself, because the process brought together so many different partners and groups of people, and that helped to build up the global momentum culminating in the UN high-level meeting. So WHO provided technical support, and we had several regional meetings. There was a WHO Global Forum, and the Russian government held a ministerial meeting in April of this year to prepare for the high-level meeting. And very importantly, there were meetings with NGOs, private sector, UN agencies, and interactive negotiations. So the political declaration at the end of the day was owned by all, although some parties would have liked to see more biting power in the political declaration. And the WHO, as I said, provided technical support, and WHO governing bodies, the World Health Assembly and the Executive Board, both were heavily involved in the preparations. So talking about evidence, we all know that there has been a body of evidence, a robust body of evidence on non-communicable diseases for a long time. And causes and determinants of major NCDs have been known through longitudinal cohort studies. And there have been very strong evidence for both individual interventions and population-wide interventions. What do I mean by this? If I can give you one example, we know that way back in 1948, the Framingham Heart Study was established. And as a result of this study, which followed up 5,000 odd people over the years, it was possible to identify the well-known risk factors: raised blood pressure, cholesterol, tobacco use, physical inactivity, diet, diabetes, etc. Those have not changed, but the body of evidence have got stronger. And of course, over the years, many other longitudinal cohort studies have added information and evidence to strengthen the case for causes and determinants. Similarly, evidence for individual interventions. There is such a big body of evidence. The problem is not lack of evidence, but implementing what is already known, as Dr. Hennigan referred to in one of the presentations in the morning. And if you remember, in the late 1990s, there was the second international study of infarct survival published in the BMJ. That was one of the most important RCTs that showed that thrombolytic therapy and aspirin both are effective in improving survival after myocardial infarction. But even this evidence, which is so old, when it comes to aspirin, aspirin has the same kind of power as thrombolytic therapy to reduce mortality. But if you look at the low-income countries, even this evidence is still not implemented in primary care. But the fact is that since then, for individual interventions, a large body of evidence have built up. However, the implementation of the evidence has been a huge problem. Now, the point is that the translation of evidence, however striking it is, sometimes may take up to a decade or more, even in high-income countries. And the evidence, of course, is the same whether you have it in the high-income country or in a low-income country. The evidence for cardiovascular disease interventions, maybe the implications may be different if the incidence of a certain condition is lower in a low-income country or higher. However, the evidence applies, but we had to have drivers to translate this evidence into action in these countries. So if you look at the different drivers that have helped in this process, there have been two. One is the demonstration that the use of this evidence in high-income countries have resulted in a reduction of mortality and improvement of outcomes. And the second set of evidence that have helped to convince the low-income countries is the availability, of course, of more reliable mortality and risk factor data in these countries. So let me elaborate that a little bit. Here you see the trends in cardiovascular disease mortality in several European countries, including the United Kingdom and also some Scandinavian countries. And what is striking is that from 1980 to 2008, there has been a dramatic decline in the age standardized mortality. And if you actually look and analyze these data as to the reason or why this declining trend occurred, from the WHO MONICA study, which was a 10-year study, one of the largest epidemiological studies, conducted in 38 European populations, the decline in mortality has been attributed to reduced incidence rates as well as improved survival after events. And across these populations with declining mortality, the reduced cardiovascular risk contributed to about 70% of the change, and 30% that was due to better survival after cardiovascular events. In the case of the United Kingdom, again, this kind of information is available. And if you look at the decline in the UK, nearly half of the decline was due to treatment, primary, secondary prevention treatment, treatment of hypertension, heart failure, MI, etc. And the other half of the decline has been attributed to the reduction in the population risk profiles. Now, as I said, the second factor, so these two factors that contributed to the decline in the developed world helped somewhat to convince the developing world that it is worthwhile putting in place these interventions. But that alone was not enough. We had to have more data, and reliable data was very much lacking in these countries. But it is only now, since about the last 3-4 years, we have this kind of data that we can present. That is, this shows the premature NCD deaths before the age of 60 years, the 2008 estimates for low income, low middle income, upper middle income, and high income countries. And if you please look at the orange part of the bars, the hatched part and the solid part. The solid part indicates the deaths under the age of 60, meaning premature, avoidable, preventable deaths due to NCDs. And the blue portion that represents deaths due to injuries, and the green communicable conditions. So what is very impressive is that in low and middle income countries, NCDs are a huge public health problem. Not only that, it's responsible for many premature deaths, which means that it's an issue which has a bearing on productivity and development, because people who are dying, quite a number of them are in their productive years. I want to stress another driver or another catalyst that has helped us to impress upon low and middle income countries that action is necessary, and that's benchmarking. Benchmarking through presentation of data. There was the release of the Global NCD report in 2008 in preparation for the UN high-level meeting, which presented the risk factor data and the mortality data for different countries. And that was quite powerful, because that led the countries to look at where they were, and there was some kind of comparison between countries. And this kind of benchmarking over the years has been quite useful in driving policy. And the work related to the global burden of diseases, that too has been helpful in generating better risk factor data, showing that prevalence of risk factors, the prevalence rates are growing in low and middle income countries, and that has also helped to stimulate countries to take action. However, if you look at this period, the 13 years, there has been great inertia, one would say, overall. So the constant question has been, how can policymaking be made more open and responsive to the influence of evidence? And this has been a continuing battle, and we have learned as we went along. And there has been many different milestones which helped us to kind of get there. For example, there were several different global strategies, I will show you 4 of them, that went through the World Health Assembly and were endorsed by all ministries of health. The first one was in the year 2000. It was called the Global Strategy for NCD Prevention and Control. It was a simple document which gave the components of what needs to be done to prevent and control NCDs: surveillance, prevention, management, equitable health care, reducing exposure to risks, and mapping the epidemic, the 3 main components. Now, the beauty of this kind of a document is not that it has any binding power on the ministries of health, but the actual process of development. This kind of document is drafted by the Secretariat, but at the World Health Assembly in May of every year, when all of the ministries of health of 192 countries come to Geneva, they spend time negotiating, debating, dialoguing, discussing, sharing their experiences on the document, and thereby they get ownership to the strategy. So this is one of the first milestones, and thereafter there was also some amount of packaging in this global strategy which helped the countries, because if you look at NCDs and list the NCDs, you have hundreds of them. So where do countries start, particularly if your resources are very little? And in this global strategy, we were able to, from a public health perspective, focus on 4 major NCDs and 4 major risk factors that were shared by these major NCDs: cardiovascular disease, diabetes, cancer, chronic lung disease, sharing tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. All 4 modifiable. And so countries could see prioritization and defining of the problem and narrowing the scope, and that helped countries to at least consider taking action. So this kind of packaging is quite important to stimulate policy, we found. Another milestone that helped the development of policy in this area was the Framework Convention on Tobacco Control, the first public health treaty that was endorsed by the World Health Assembly in 2003. And this has now, of course, been ratified by 90% of the world population, which is 170 countries. And then countries have taken advantage of the global momentum of the FCTC to put in place tobacco control policies. And this treaty, which is kind of binding on the countries, has been quite effective overall in getting tobacco control policies in place. However, the struggle against tobacco is not over because, of course, the industry has been shifting its focus to low and middle income countries increasingly, with a particular emphasis on marketing to children, the young, and the women. And so as a result, you see more and more the prevalence rates in these vulnerable groups increasing. So in the case of NCDs, policy development and action was also difficult because of these kinds of forces, the industry forces and the vested interests that always complicated the situation. Another strategy that also went through the World Health Assembly in 2005 was a global strategy for diet and physical activity, which also had a set of recommendations for marketing food and beverages to children. And this was to counteract the extensive advertising and other forms of food marketing to children. And there were recommendations in this set for national and international action to reduce the impact on children of marketing of foods high in saturated fat, trans fatty acids, free sugars, and salt. And this was accompanied with a strategy for diet, physical activity, and health, which again informed the ministries of health of the need to focus on these risk factors. That is not to say that all countries put in place policies for these risk factors. And then finally, in 2010, last year, there was also the strategy for reducing harmful use of alcohol, which is linked to NCDs, which again would help countries in the implementation processes. And another tool which was helpful to countries was the NCD action plan. Here again, it was an action plan to implement the global strategy for NCD prevention and control, which was endorsed by the World Health Assembly, meaning that 193 countries accepted it. And there were roles and responsibilities spelled out for the WHO, for the member states, for the partners across 6 objectives. And the 6 objectives focused on according priority to NCDs in the development agenda, considering it in policies outside the health sector, because NCDs are determined mostly by determinants outside the health sector, and also establishing and strengthening national policies and programs, reducing risk factors, prioritizing research, particularly implementation research, strengthening partnerships, and finally monitoring. So these were the 6 objectives, and this NCD action plan helped some few countries to go forward in their policy implementation. So this summarizes for you these tools that I alluded to, from the global strategy to the treaty to the NCD action plan, finally culminating in the UN high-level meeting. And another factor that helped to strengthen the policy response was the gathering evidence that linked NCDs to poverty, because there was always the concern in the minds of people in countries, particularly the policymakers, that spending and investing in NCDs would incur opportunity costs on communicable diseases, and also that it's a condition, or there are conditions that are associated with aging, and they are inevitable. This kind of misconception was there. But lately, over the last several years, now evidence has gathered linking poverty with NCDs. For example, this diagram that you see here shows on the x-axis out-of-pocket payment as a proportion of total health expenditure, and on the y-axis, vertical axis, percentage increase in poverty as a result. You can see countries like Bangladesh, China, India, Nepal, as a result of out-of-pocket expenditure, a large proportion of people are getting into poverty. Those who are in poverty, they get worse, of course, but there is an increase in the poverty head count, because these conditions are chronic and they need long-term care, and particularly if they are diagnosed at late stages, they need high technology, expensive care. So the difficulty that was experienced in translating what is known into policy, although so much is known about NCDs, so many interventions are available and have been shown to be effective, shows us that policy decisions are not made by evidence. At best, policies can be informed by evidence. Because for a policymaker, it's not possible to look at a single systematic review or cost-benefit analysis and decide whether or not to enact a policy or give funding to an intervention. This decision has to be considered in the context of many other factors: the social, political context, competing health priorities, availability of funding, opportunity costs, etc. So the business of translating and transforming evidence into policy is quite a difficult area of work, particularly when resources are limited. Here I have attempted to list for you some of the levers that I already alluded to that can be helpful when you want to translate evidence into policy, like packaging of NCDs that I mentioned for the global strategy, success elsewhere that you show as an example, data, benchmarking, legal tools, and also making a condition a development issue. Now I want to take a few minutes to focus on the barriers and what we have done, a few lessons that we have learned, and to showcase a few tools that we have developed to try and overcome the lack of program budgets, the issues of affordability, feasibility, the issue of priority setting. Because one of the biggest problems in the NCD arena is the lack of resources, particularly in low and middle income countries. Here you see the donor commitments by health sector discipline. For 2009, you can see we had like 21.7 billion, the total ODA and other donor commitments. But if you look at what this money was spent on, you can see HIV/AIDS, TB, malaria, infectious diseases, reproductive health and nutrition, all very important problems. Health in general, basic health and hopefully health systems, but no mention of NCDs at all. Although 63% of the mortality currently is due to NCDs and 80% coming from the developing world. So this situation could only be changed by bringing NCDs into the development agenda, and that's what the UN General Assembly hopefully did, and there should be results from that. And here is a domestic investment, and that's not a pretty picture either. You can see that there are many countries, about 500 countries, about 100 countries spend less than $500 per capita on health. And there are some countries that spend $50 per capita on health. And there's very little you can do for NCDs if that is the kind of domestic investment. So these things were highlighted in the UN General Assembly political declaration and hopefully should stimulate countries to invest more if they are really serious about addressing non-communicable diseases. However, the key question is, how could evidence be translated into meaningful action in the face of limited resources and capacity? Because this situation with resources will not change overnight, will not change for several years probably. So we need to catalyze appropriate investment in preventive and curative health care so that there is equity. And in order to do that, there has got to be some direction regarding priority setting, and also evidence generated on impact, affordability, and feasibility of interventions. So for the last 2 years, in preparation for the UN high-level meeting, WHO undertook an exercise to try and identify the basic, essential set of interventions that we can recommend to any country as top priorities. And in doing that, we made sure that we combined population-wide and individual interventions, because for taking action on NCDs, it is absolutely necessary that you do that, a combination of population-wide and individual interventions. And then we focused on all low and middle income countries that had a large population. So we took 42 countries which accounted for 90% of the NCD burden, and we estimated the cost that will take to implement 14 basic interventions. And I'll show you the set of basic interventions that we chose based on several factors. One, the evidence of impact. Two, affordability. And three, feasibility of implementation, particularly in primary care, where the health systems are really very weak in these countries. So for tobacco, we had 4 interventions that we identified, which had strong evidence and which satisfied all of these criteria. For harmful use of alcohol, 3 interventions that are listed there: raising taxes on alcohol, restricting access to retailed alcohol, and enforcing bans on alcohol advertising. Similarly, for unhealthy diet and physical inactivity, reducing salt intake, replacing trans fat with polyunsaturated fat, and promoting public awareness about diet and physical activity. And then for cardiovascular disease and diabetes, providing at least 4 medicines for people with high risk, and also for people who have already had heart attacks and strokes. And there were 2 interventions also for cancer: hepatitis B vaccination and screening for cervical cancer, which is not shown here in the slide. So 14 interventions. And what kind of cost are we talking about? And once you calculate for the 42 countries and scale it up for all of the low and middle income countries, the global price tag was $11.4 billion per year on average. But if you take it per head, it was only US $0.2 per head for low and low middle income countries, and double that for upper middle income countries. For individual interventions where medicines had to be given for cardiovascular disease and diabetes, the costs were higher, about $1 per head in low income and about $2.50 per head for upper and middle income countries. So this information, as you can see, shows very clearly that the cost is very high for individual interventions, although you have got to have this combination. And the population-wide interventions, the cost is not very high for implementation. And this was released before the UN high-level meeting to give the countries 3 messages: that the cost of targeted investment in NCDs, it's not very high, and these we call them best buys. The budgetary impact of NCD scale-up is modest, and they can make a start, and that every country could make a start, that they need not give the excuse that resources are not there, but at least with the available resources, with some little increase in domestic investment, that they could start focusing on these best buys. And this was released in New York the day before the UN General Assembly meeting. Now, regarding evidence, there has been an area where evidence has not been very strong, and that has been in the area of intersectoral action. The nature of NCD policies is such that most NCD policies, particularly for population-wide primary prevention, are intersectoral. For example, transport policies or agriculture policies, and evidence is quite lacking in this area. So it was very welcome, the previous session this afternoon that this meeting had organized for you about complex interventions and how to conduct research in that area. So multisectoral policies like transport, agriculture, exposure to, for example, advertisements of children, etc., what to do about them, the interventions and gathering evidence, that's quite complex, and that's an area which is very weak worldwide. So I would like to kind of summarize there. To drive the non-communicable diseases agenda, we had to strengthen evidence for rational investment, but also had to facilitate translation of evidence to policies by various means. We used evidence wherever that was available, and evidence placed a major role. Evidence was articulated into strategies, like global strategies. Evidence was articulated as NCD action plans that countries could put in place. Evidence-based public health treaties were enacted, and evidence was presented in the form of better epidemiological data from countries. And evidence was also gathered on the impact, feasibility, cost of interventions, and particularly affordability for countries. And very importantly, cost of inaction versus action. Business as usual would cost countries too much if they were not prepared to take action. Now taking action later would be much more costly, and this evidence has been generated now and is available for countries to see. So there was constantly over the last 13 years an analysis of factors that affected the policy environment, both the levers that you see on the left-hand side that I alluded to, and also the barriers, but more importantly, how you could try and get around those barriers. The affordability, feasibility, priority setting issues, and lack of program budgets, etc. And in translating evidence into policy, we have to remember that evidence is generated by researchers and technocrats and policymakers often who don't understand evidence, they are enacting policy. And bridging of these two groups need to take place as an explicit affair. And there is the need for tools for leveraging the policy environment for this purpose, and also we need knowledge brokers like the media, knowledge brokers like civil society groups, knowledge brokers like the British Medical Journal, the Lancet, the professional associations, in order to give it the advocacy that it needs, any public health issue, not only NCDs. And in taking the NCD agenda forward, finally, we have learned valuable lessons, how to overcome the challenges for evidence-informed policymaking, and how policymaking may be made more open to the influence of evidence. Of course, it has been some years, there had been great inertia, and it has been very depressing. But right now, of course, after the UN high-level meeting, the opportunities for taking the NCD agenda forward has never been any better, and everyone is very hopeful. Thank you very much.
Hello, my name is Donald Coyd. I actually live in China, where I think 55% of men smoke, and I guess that may be the biggest challenge that the UN and WHO have got in the world. And I was just wondering, you have just said that it's you're in the early stages of moving in this direction, which is very good, but I wonder if you've got any small success stories that the Chinese might take note of, maybe in other countries.
You bring out a very important issue. China with 1.2 billion people, I mean, as you say, 50% of smokers, that's like a disaster waiting to happen. This has been highlighted in WHO literature, not exactly like that, but giving the prevalence rates in China, as opposed to, for example, Uruguay, where you have a Minister of Health who is a doctor who has taken very stringent measures to control tobacco. And it has been highlighted and showcased, the Uruguay example and several other countries, Thailand, for example, to try and get the Chinese authorities to take note. But as with all policy making, that's the best that one can do. But you know, the efforts are being made constantly, and that's a very important issue for China.
I was just going to ask Shanti, it seemed to me that quite a lot of the drama at the big meeting was around commercial interests and how those played out. I mean, obviously you've got the evidence and you've got, I suppose, policymakers willing to look at the evidence, but if they've got immensely powerful, well-funded voices, like the tobacco industry, telling them that, you know, they should do differently, how can we overcome that? How can evidence be brought to bear? I mean, and the food industry, likewise, the drug industry, yeah.
They were all there at the table, Fiona, and you bring out one of the most sensitive as well as very important issue. This is the role of the private sector, but there is increasing realization also that they've got to be part of the solution, that we have to try and get them to be part of the solution one way or the other. When the Framework Convention on Tobacco Control was enacted, and that was kind of successful, a lot of people felt that we should go along the same way to get the food industry to comply. But soon it became clear it wouldn't work for food, neither would it work for physical activity, because those are not things that one can sort of ban, like tobacco. But you could see at the high-level meeting, there was the presence of these powerful groups lobbying and also trying to influence the political declaration, and this would be a constant struggle. And there's also, I think, increasing advertising campaigns now being launched to try and dampen whatever the impact the political declaration may have. So it will be a continuous struggle into the future, because it is hurting the profits of these companies.
Thank you.
I recently had the privilege of teaching in Botswana for two weeks and saw at close hand the Botswanan healthcare system. It's a very small country. What really struck me was how distorting the interests of the NGOs were, because they were only interested in investing in HIV. And also the high proportion of expats who were working in the country and who all had their own agendas and their own research interests, and they were driving the system. So it was interesting that you put NGOs as a lever, because from my observation in that particular country, which may be very different in different countries, I would actually have put those on the other side, in the barrier side. And I was really quite stunned by how distorting the priorities were of those two groups.
You are quite right in a certain sense, because in some of these low and middle income countries, particularly the low income countries, the number of NGOs that you have in a country, the numbers are so vast, and the problem is that they don't align at the moment their work with the Ministries of Health agenda at all, or with the donor commitments and the donor agendas, and they try to get funding and do their thing, as you say. And the same applies to expat researchers. So there's a great deal of work that has to be done at the national level, and the national level NGOs and the partners and the stakeholders, it's an extremely crowded scenario at the national level, more than even at the global level. And the national level, Ministries of Health, unfortunately, they don't have the capacity to bring them all aligned together. So WHO has tried to do this, and even with the UN agencies, we have different UN agencies, trying to get them to go in one direction will be a challenge. And indeed, the political declaration calls for this, an interagency collaboration mechanism to get these agencies and the NGOs, as well as even the private sector, to align their efforts with the interests of the government and the people of countries. But that's a very difficult issue at the country level.
Thanks. This may be an extremely naive question. I'm just a London GP, but I'm just intrigued, to go back to the previous question, just intrigued to know, given the strength of the evidence, what arguments are still left for the tobacco industry to deploy? I mean, what earth can they still be saying?
It's the tobacco growers. I mean, I gather, isn't it? Certainly in China, that's one of the things I've heard. Huge economic problems of unemployment amongst those who grow the tobacco. That's one of them.
Yes, that's certainly one of the arguments they use. But there have been studies since the treaty was enacted to show that actually even to soil and agriculture, tobacco growing does more damage than good in the long run in terms of erosion and making it kind of unproductive. So really there is enough evidence, I would say, as you quite rightly point out, to make tobacco disappear. But the point is that there is a certain amount of corruption. People are taking, they are getting cuts out of all these, and at the highest levels, there is some amount of collaboration with the tobacco industry, which shouldn't be there at all. So that's often the cause of it continuing.
Thank you very much, Shanti, for highlighting the importance of bringing together the practices and evidence, and how evidence could improve policies and practices. I have been studying evidence-based social interventions for the last 2 years, and I was trying to translate my knowledge into and connecting it to the practices to my country, India. And first of all, I feel that there is an issue of political willingness in adopting this change, that adopting evidence and adopting it into the practices actually. And certainly there are many public issues related to it. When you ask people, when you approach people with evidence that smoking is dangerous, then there are other political repercussions for the political parties. Second thing which comes to my mind is transportation of evidence from Western setup to the lower income countries. Context and situations are entirely and almost different. So I wonder how you approach these 2 points. Please, thank you.
I completely agree with you about political commitment, and the political commitment component becomes very difficult in some countries also because of the changing political leaders sometimes even, but political commitment is a must. The second issue of research, as you say, what is most important is operational research, implementation research. Evidence is available on what works, but how to make it work in a particular context, that is lacking. So even in the research agenda that WHO prioritized last year, we have given top priority to some of these areas in the operational research range. So that area is quite weak.
I mean, thank you for the talk. I just have a worry that, again, we have a vertical intervention coming because the long-term condition is a priority because it's a growing problem. And I think thinking about the issue with HIV, where we saw HIV being driving the investment in, for example, in African country, what is the evidence that taking long-term condition as the agenda and driving it to implementing will benefit instead of trying to integrate and look at the health system as a whole with the capacity to address the needs of long-term condition. HIV is becoming a long-term condition. So I think what I will question is a bit, are we going again to take one vertical intervention, knowing by experience that it had detrimental effect on the health system in developing countries?
Yes, this issue of vertical programs as opposed to horizontal, there have been a serious debate about this, in the recent couple of years. But the point is that you don't necessarily need to take it as a vertical program, particularly now where health system strengthening has been given top priority. And whatever you bring in for NCDs has got to be on that platform of health system strengthening, and WHO prioritizes everything to be integrated. And in fact, one of the side meetings at the New York high-level meeting was how to exactly do that, how to integrate and build on the lessons learned on the HIV AIDS experience, and also how to integrate even from the programmatic point of view. Although there's very little evidence on what works in this integration between HIV AIDS and NCDs. People talk a lot about it, but actually whether it works, whether it is effective, whether it is operational, this area is not very rich in evidence. But I totally agree with you, integration has a lot of added value.
I'm Geraldine Racaza. I'm a rheumatology fellow in training from the Philippines, so clearly I belong to the low to middle income countries. I was just wondering if included in your non-communicable diseases is osteoarthritis when you discussed this in September 2011, because as we know, it's becoming the most disabling disease, or one of the most disabling diseases in worldwide actually. And this is so because of the increasing geriatric population as well as the obesity epidemic all throughout the world. So I'm just wondering if this is part of the WHO topic or importance or something.
Osteoarthritis is obviously a very important health problem given the aging populations in countries, even in the low income and middle-income countries. Now, what WHO has done in prioritizing the 4 major NCDs is not to leave out these other NCDs, and no one is saying don't take action for osteoarthritis, but indeed, if you take measures to improve physical activity, for example, that would help osteoarthritis. So there are indirect benefits, and also it is the same when you are strengthening health systems and strengthening primary care, that is not only to address the 4 major NCDs, but also to address other NCDs as well. So there's going to be benefits for osteoarthritis, renal diseases, skin diseases, etc., etc. But the prioritization is based on 4 main reasons. One, the contribution of the 4 major diseases to the global burden, it's significantly high. 2, the evidence of cost-effective and affordable interventions that can be implemented in primary care, and interventions also that are feasible to be implemented at the primary health care level, and the level of impact and preventability. So these were the factors that went into the prioritization, and that is not to say that osteoarthritis is not an important condition.
I promise that I will mention climate change at every meeting I speak at, and this is my moment. It seems to me, Shanti, that what you were just talking about, the co-benefits of attacking the 4 big NCDs in terms of osteoarthritis, but I wondered whether climate change and the kind of health co-benefits of a lower carbon lifestyle came up at the NCD meeting.
It did from the sustainable development point of angle, and also for poverty alleviation, and in linking to the Millennium Development Goals. It did come up in the negotiations. I don't exactly remember, I must say, whether it is in the political declaration in those words, but I have a vague recollection it is, but certainly sustainable development is.
Hi Shanti, I was very interesting. I think the thing I'm going to, which I'd like to throw is for like the infectious diseases world, I think it's easy to show differences. And in the chronic disease world, it's going to be a long haul for the WHO. If you improve blood pressure treatment, it's 5-10 years before you'll see the gains in healthcare. And I just wonder how the WHO is going to continue to sort of fund and keep the sort of impetus going with non-communicable diseases over the long term, if you like, because it may be difficult to show early wins.
Thank you, Carl, for that very important question. The sustainability of all these efforts, the long-term nature of the support that is required, it is really critical for NCDs, as you quite rightly point out, both in terms of support for countries and also efforts. And here there will be some interventions like, for example, primary healthcare strengthening or integrating for looking for medium-term outcomes of blood pressure control, etc. But indeed, hard outcomes will take years to manifest. So a decade or so of commitment is required in this regard. And there were some calls by some countries to put in place a global fund, and some other countries opposed this for this very same reason. And their point of view was that HIV/AIDS is chronic, but it is not as chronic as the non-communicable diseases, which are lifetime diseases. So if you put up a global fund, and the countries don't really make an effort to raise domestic resources, what would be the situation 10 years down the road when the global fund dries up? So this issue is very critical that all partners and also the countries really look at it quite seriously.
Just to add to that, one of the, which Fiona just pointed me to, was this, which is new to me, it's always good to learn a new thing, it's the PEN list, which is, as opposed to your essential medicines list, is this list of essential drugs and devices for non-communicable diseases, which is sort of new to me. And are you still promoting that, or do you see that as a way forward to help low-income countries?
Do you want to just say a little more about the PEN list, Shanti? Because people may not know what it is.
Yes, let me explain, Carl. Now, when you take the essential medicines list, there are some 400 odd medicines in the model list of the WHO, and even for a middle income country, it's not possible from public funds to fund that. Nevertheless, they are identified as essential medicines, and for NCDs, they are not 400 of course. For NCDs, I think the list runs to about 50 odd or 60 odd medicines. So what we have done here is we have taken a minimalistic approach and said, okay, provide 10 medicines, and these are the 10, and they are for cardiovascular disease, diabetes, And if you want to expand it, it's inhaled steroids for asthma and salbutamol for asthma, and that's it. So the list is 10 to 12 medicines. And we are saying, okay, countries don't have funding, and this is given as an excuse often, oh, we don't have money to provide 400 medicines that are there in the WHO medicine list. So from the NCD point of view, in order to get countries to start now and to scale up later, we are saying, okay, start with these 10 or 12 medicines. So that's the medicines. And now these interventions that I referred to, there are 14 interventions, and these interventions have been taken out and packaged as best buys because they, when you look at the cost effectiveness, they are highly cost effective, all the 14 interventions. In fact, in the 14 interventions, we couldn't even put asthma because the current cost effectiveness evidence does not show that it's highly cost effective. But this set of population-wide and a few individual interventions targeting cardiovascular disease, diabetes, and cervical cancer and liver cancer. These are highly cost effective, number one, low cost to implement when you actually cost in the modeling, and also feasible to be implemented in primary care, either at the primary care or at the policy level. So these 14 include some of the interventions in the WHO PEN set, but not all. So the WHO PEN is kind of an expanded list for primary care. If countries have more money, they could expand it to include also cardiac failure, include also renal disease, include also, and then that set is much broader. And the point is that countries are very reluctant to make a start, although WHO says universal coverage, but how they are going to get at the universal coverage is well, I mean, there's a big question mark without resources. So the message is start with the best buys, then expand it to the WHO PEN list because that would be the next expanded set, and then expand further as you think fit. And
PEN stands for?
The package of essential NCD interventions for primary care.
Oh, package, okay, very good. Yes. But can I just briefly, I had heard that WHO had shelved the PEN list, but that's not the case, or they have shelved it.
No, the PEN list was the one that contributed to the best buys for the individual interventions. And because we had done the PEN list, we were able to take the most cost effective of that lot to put to the best buys. But the rest remain, and the rest at the moment, some countries are even implementing.
Amanda Adler, Cambridge. You talked about cost effectiveness, and that's presumably cost effective against doing nothing, I'm guessing. But related to cost effectiveness, in Britain we kind of have an idea what's cost effective, and we talk about sort of 20 to 30,000 pounds per quality adjusted life year. Is there a global sense of or definition of what is cost effective in terms of a number?
Yes.
And if so, what's the unit of effectiveness?
Yes, there's a definition in relation to the GDP, Amanda. I can't offhand give it to you accurately, but I can send it to you. There is one for highly cost effective and one for moderately cost effective in relation to the GDP and how much money you spend in relation to the GDP.